So what do you do if you fail an IVF cycle? I'm Dr. Sharon Moayeri, owner and founder of OC Fertility. There's really different stages of failure, and so I'm going to walk you through that. The first stage is if you fail to have any embryos to transfer. So that would involve going through an egg retrieval to transfer either one because none developed to the stage where they are usable. So either if you're doing a blastocyst transfer, which is a 1-week embryo, or if you're doing a day 3 transfer, which is a cleavage embryo, which is less commonly done today, then you may not have had anything usable. Sometimes you get to the blastocyst transfer and you do what's called pre-implantation genetic testing, which is commonly done. It's something we do quite often in our practice. That's when a few cells are removed and sent off for genetic testing. The genetic testing of the chromosomes may come back where there's no healthy embryos to use, in which case you have nothing to transfer for that cycle. Failure from the egg retrieval side can come from many different reasons, and it's generally related to the age of the couple, specifically the age of the woman. And so you want to go in with the right expectation. So age is an important predictor of that outcome, as well as the number of eggs that are retrieved. But certainly when we have patients who are coming to us who are younger and not conceiving, we are sometimes surprised to see that they may have a higher than expected number of abnormal eggs. Or if you're going into IVF with not only infertility, but maybe you have a single gene disorder such as cystic fibrosis or muscular dystrophy, then you're going to need to have really a lot more eggs in order to find a healthy embryo, because your embryos are going to have to pass a lot more tests in order to be able to be used for transfer. So the first thing I always do is set the expectation, because some patients may not have the opportunity to extract a lot of eggs based on their biology. So if they have a low AMH, or if they have a low antral follicle count or a high FSH, then they should go in with the expectation that they may need more than one retrieval in order to find a healthy embryo. If they're going to be doing family building where they plan on having embryos for future children, then they also might be needing multiple retrievals to bank embryos for the future. So that's the first point. And once you get to the end of that cycle, if you have no healthy embryos, it doesn't mean your next cycle won't have healthy embryos. And so what I usually do is look at the protocol that we used and see if there's things we can do to improve upon that. What did we learn from that cycle? Are there things we can do differently? We also look at the couple's lifestyle factors, anything they can do to improve the outcome. Again, we focus a lot on the female partner, but sometimes there's things that the male partner can do as well. If there's a male factor, that might involve looking more thoroughly at his side of the equation, perhaps getting a urologist involved to see if there's anything that needs to be done surgically on his side or medically. So if a patient or a couple goes through and doesn't have healthy embryos to use from a cycle, it doesn't mean that they wouldn't have the next time around. What we can do is go back and learn from what we did, see if there's any areas of improvement, and try something different the next time around. I always encourage my patients to not give up hope, especially if they're older. There is the expectation they may need more than one cycle. If their antral follicle count or their AMH is low or FSH is elevated, these are expected sometimes that they may need more than one cycle to achieve their goals. And then we try something different the next time around. I let them look at some of the factors that they have control over and see if there's anything they can do with lifestyle. And again, focus on not just the female partner, but the male partner as well. Sometimes we need to have involvement from the urologist if there's any surgical procedures or medical management that may benefit him as well. So we talked a little bit about if you fail IVF from the standpoint of not having embryos to use. But then there's the side of what if you have embryos to use, but you fail implantation. So you do an embryo transfer, but you keep getting negative pregnancy tests. Or some people categorize also biochemical pregnancies, where you get a positive pregnancy test, but it never makes it to the stage where you actually can see a pregnancy in the uterus. So one of the more common things to think about with an embryo transfer failure is the embryo. So was it tested or not chromosomally? Sometimes the testing, if it was done, may not be accurate. Sometimes the testing may have damaged the embryo, although this is less common to be the problem. So those could be things to consider. And then just because we tested the embryo for chromosomes doesn't mean that there aren't other factors in the embryo, such as metabolic development, that might affect how it implants. So that's something to consider when you're looking at why the embryo didn't attach to the uterus. So most common things we're looking for are structural defects. These can be polyps, which are overgrowth of fleshy tissue in the uterine cavity from glandular cells, or fibroids, which are overgrowths of muscle cells of the uterus. These can enter the uterine cavity space and interfere with proper implantation of the embryo. There could be other changes in the uterine cavity that involve changes to the environment, such as inflammation or infection from bacteria. They're not always related to sexually transmitted infections. They can be from bacteria that tracks into the uterus. And in fact, things related to microbiome changes to gut health can also influence that environment. So focusing on that is very important sometimes for implantation health. So sometimes it can be related to something going on with the woman's body. Maybe she has an autoimmune condition or a clotting disorder that hasn't been recognized. Usually you see those with miscarriages that occur later in pregnancy, but there are some patients who might have recurring implantation failure or early miscarriages, and so it's worth screening for, especially because those conditions can affect pregnancy, and it's good to know about that ahead of time. The other thing we want to know about is maybe the timing wasn't right. Maybe the protocol that was used wasn't optimized in particular for that patient, so she may need a more personalized embryo transfer protocol. This area is a little bit controversial. Some people don't believe in these customized protocols, but there are some things called mock embryo transfer testing that involves what's called an endometrial receptivity assay, or abbreviated ERA. And then there's another test called a receptiva that screens for endometriosis. These are different tests you can do to screen for changes in the endometrium that may alter implantation potential. Last but not least, sometimes it's just chance. We don't expect 100% pregnancy rates. We usually, at best, see somewhere between 70 to 75% implantation per embryo. And so there is a certain degree of chance to every embryo transfer. And so unless you're having repeat failed implantation, some of it's just going to be due to chance. We also want to make sure that the hormones were adequate to support implantation. So usually for these different protocols, we're giving patients estrogen and progesterone. Sometimes we're doing what are called natural cycles, where we're just following a woman's menstrual cycle and then reinserting the embryo around the time that it would naturally be entering the womb. And so we want to make sure that her estrogen and progesterone were adequate to support implantation potential. So I often tell my patients after a failed cycle, whether it's an egg retrieval or an embryo transfer, to not give up hope and to keep trying, because usually they'll end up with a healthy baby at the end of it.